of KCOG, Dr. Vidya Bhatt, and Treasurer, Dr. Suman Gaddi, and also our dear Bharti Rashekar ma'am, the President-elect for KCOG in 2024. I extend my warm welcome to our speaker, Dr. Pooja, who, in spite of her busy schedule, has heartily accepted our invitation for the program today to give her comments about the fetal surveillance in high-risk obstetrics. And Dr. Pooja has been a chairperson for the Fetal Medicine Committee of AMOGS for the year 2020-2022. And we have all heard on various forums of the way in which she has mastered her acumen in fetal surveillance. Hearty welcome to you, Dr. Pooja. I also welcome all the delegates who have logged in for another interesting session, and as diligently and responsibly every month we try to keep up with the KCOG activities, and behind which is the master, Dr. M.G. Hiramat sir, who sees to it that we stick on to the teaching program, the learning webinars, in spite of come what may, that we need to be effective in our efforts to bring on these discussions. So I now request Mr. Arun to please do the lighting of the lamp and inaugurate the session.
आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you, Arun, for the wonderful divine invocation song, which always keeps us blessed by the knowledge and by good health. I now request our President, ma'am, Dr. Vidya Thobi, to give her address.
Thank you, Rajeshri. And I think the topic today, which is chosen as a fetal surveillance in the high-risk pregnancy, is very apt. As all of us know that surveillance we define as a close observation, and the fetal surveillance in antepartum and intrapartum is very, very necessary nowadays to reduce the perinatal mortality and morbidity. And it should not translate, of course, in unnecessary iatrogenic preterm deliveries also. Yesterday, we had a very nice panel discussion where these interventions were nicely discussed yesterday. So today, I will not take much time in talking about fetal surveillance. Let us listen to the star of the today, that is Dr. Pooja Lodha, and our dear patron, Dr. M.G. Hiramat, for his expert comments. So over to you, Dr. Pooja.
Before that, I would request our patron sir, M.G. Hiramat sir, to give his word of introduction and briefing about the subject for today evening. Over to you, M.G. Hiramat sir.
Thank you, Rajeshri. It's nice that all our office bearers have joined after a Paris visit. Probably they are maybe in very high. But let me come back. Now, why I selected this topic was, am I audible?
Yes, sir.
Yes, sir. You are audible.
Now, why I selected this topic was, I just wanted to share my last 40 years experience in this field. I joined as a postgraduate student in OBGYN in 1982. Probably Pooja must have not been born. And at that time, you see, the fetal surveillance was nothing but just examining the abdomen of a pregnant woman, feeling something odd, something soft, something moving, something not moving, and putting a stethoscope, trying to hear the heart sounds either in the front view or in the back view. Even after 15-20 minutes, sometimes the fetal heart sounds were not heard. And at the end of the day, what we used to see as a postgraduate is, let me remember those days, in a month, probably 3 to 4 anencephalies were born because they were never, surveillance was not done. Ultrasound machine was not available. For the first time, I saw the ultrasound machine in 1982 when I went to Mumbai, where our great Dr. S.N. Daftare had organized a training program for few of the gynecologists. And in 82, 85, I saw first time machine and I saw the image of a fetus on the screen and I was so thrilled. And that you can see so many parts of the fetus and so diligently and so much of surveillance can be done. And immediately I ordered for an ultrasound machine, Aloka machine at that time, which was available for 3 lakhs. Then I started using ultrasound machine to 4 districts of North Karnataka. And I was taking the machine to rural area where they were conducted in villages. And I was charging 30 rupees for fetal surveillance. Today, if you go to Pooja, she will be charging 3,000 rupees for surveillance. And what a tremendous advancement has occurred is that with the advent of ultrasonography, with the addition of a new specialty in OBGYN, I think Vidya, when we just became postgraduates, we had only two. One is become an obstetrician or become a gynecologist. Go on doing prolapse surgery, not all gynec surgeries, only prolapse. Our list used to be 10 to 15, of which 7 to 8 used to be prolapse, no other condition. From those days, now we have got 15 to 20 super specialties. I think quite a wide range of programs we have. And the newer addition for this is fetal medicine. I think today, when I inquire most of the postgraduates, what they will tell me is either I want to become an IVF specialist or I want to become a fetal medicine consultant. And choice is becoming more and more for fetal medicine. Probably the art science has grown so much. And now looking to the Pooja's biodata, what a wonderful biodata she has got. She has got all the art which is done in the fetal medicine. Be it be an ultrasound for prenatal screening, diagnostic testing, genetic counseling, preconceptional counseling, fetal diagnostic and therapeutic procedures like amniocentesis, chorionic villus sampling, fetal blood transfusion, selective fetal reduction, fetal centing, whatnot. These were never heard to us when we were younger, the gynecologist, younger specialty. And we are very lucky that Pooja has agreed for this today's program. And we know all of us. She is another junior Sunita, brain and the beauty, which have joined together, and the way she has got exposure and the way she is doing a lot of work in Pune. I hear from many of my friends that if at all you want to get a second opinion, you send it to Pooja. She is the right person. That's why I sent one on WhatsApp other day, because I do my ultrasound, all ultrasound. And this was a 42 years old lady, and I saw twin gestation with the ICSI treatment. And just Pooja said, yes, sir. I just said, I have seen the fetus. What she told me is, she told so many things in that. It is dichorionic, it is that, it is this, so many things. So much of advancement has occurred. It is great that our women are being given this benefit. And today, they are lucky people. Every woman who has become pregnant, she can know her fetus so well, right at the beginning of the pregnancy by 6 or 7 weeks. And surveillance is starting right from there. Earlier, surveillance means used to be only at a later part of the pregnancy, looking for other parameters. I think this fetal surveillance has become a very major one, and more so in high-risk pregnancy. Today, in high-risk pregnancy, you have to see the fetus not only once in a month, you may have to see twice in a month, you have to see once in a week, or sometimes you have to see alternate day also. That means so much of advancement has occurred, and this fetal surveillance, I think Pooja will give us a very wonderful dipto. I hope our postgraduates will be definitely benefited. And now the platform is yours, Dr. Pooja. After that, we have got a question hour session, and we have got a small discussion session. And Pooja will definitely enrich our knowledge on this specialty. Welcome, Dr. Pooja, once again. Now it is yours.
Thank you so much, sir. Shashtang Namaskar to you, the master of this orchestra, KCOG and KCOG. Respected all seniors, Dr. Vidya Thobi ma'am, Dr. Bharti ma'am, Dr. Rajashri ma'am, Dr. Vidya Bhatt ma'am, Hema Devakar ma'am, and everybody who's not present as well. Thank you for this prestigious opportunity. And I'm so excited to be here, but let us also leave a lot of time for discussion. And today I wish to take you all through fetal surveillance as well as maternal surveillance from a fetal medicine point of view in high risk pregnancies. So I will just share my screen, and I would want to tell you that instead of going into the technicalities of how to scan and what to see on the scan, what has become really important is, as a receiving obstetrician or a high risk obstetrician, when you receive that report, whether it be a HbA1c or a double marker or an ultrasound or a Doppler chart, how to interpret it, all of us be on the same page and do the most optimal thing required for the mother and the baby with an excellent counseling. So the communication becomes equally important, and this is what I wish to take you all through. So in Pune, we have the India-Bangladesh match, so I couldn't resist putting this up, that this is my innings today. And we are going to discuss the fetal surveillance in maternal disorders, in diabetes, thyroid disorders, hypertension, Rh negative mother, epilepsy. To start with, I will begin with the general principles of fetal care in high-risk pregnancy, and these principles apply to all women who are high risk. It could be a 42-year-old, it could be a twins, somebody going into threatened preterm, somebody with a pre-existing hypertension, diabetes, any of the above. So whatever we label as high risk will go through these general principles. And of course, we will discuss the holistic multidisciplinary approach, antenatal steroids and Maxalt for neuroprotection. So yes, you can keep posting your questions in the chat box and I'll be happy to answer them. And I wish to learn from all of you and look forward to your inputs as well.
And there's your beautiful baby. Any day now. Really? You're eating Doritos? He's eating Doritos on my ultrasound. Do you see what I have to do? I know. Give me that.
So this is how the babies make us run around nowadays. All the decades when Hiramat sir was telling me, yes, indeed, I wasn't even born in 1982, sir, when you did this magic rocket science with ultrasound. And the baby, the fetus used to be just a part of the mother. So when the mother has come, take your weight, take your blood pressure, okay, listen to the fetal heart rate and go away. So fetus as a patient is a relatively new concept. And now we concentrate on individuality of fetal disorders and their management. It is always recommended that we consult the required fraternities when a problem comes up, and we try not to deal with everything on our own. As and when I go through the slides, I will keep mentioning how to use this multidisciplinary care. For all of those, in fact, the PGs who have logged in and who feel that all this is the luxury of a metropolitan city like Pune, Bangalore, etc. No, it is not. COVID has brought us closer, and so many online consultations are happening in the periphery, in the villages, with a clinical geneticist, with a pediatric cardiologist, because the amount of information given and the way it is spoken is the same, whether you sit across or you talk online. So this is a very good way of bringing the world together. And yes, all of us can avail this multidisciplinary care. So the basic principles, all the time when we reach term with all the high-risk pregnancies, we are worried, what is the gestational age? Is it okay to deliver her? Is it too early? What is the weight of the baby? 900 grams, is the NICU good enough? Should I give Maxalt? How many steroids? I've already given it. Do I deliver at my nursing home and then shift the baby to another NICU? Or should I do an in utero transfer and then deliver the baby, because the golden hour is the most important after the birth of the baby, and we should not waste that time in running around and transferring the baby. So a constant balancing act that we as obstetricians have to play, whether we want to leave the baby inside for long and pose the risk of fetal acidosis or even IUD, or we want to deliver iatrogenically earlier, maybe at 32 weeks, 34 weeks. But depending upon the NICU facilities, how comfortable your neonatologist is with that particular gestational age and maturity, and then dealing with the long-term and short-term problems of fetal prematurity. So general principles of management. We come to the antenatal steroids. Although it sounds very easy, but we get a lot of places in Pune itself, I know, are were going through a wrong dose of a wrong molecule at the wrong time. And guidelines have also changed. So it may look simple, but a lot of times when things go wrong and we think, what exactly went wrong when I've done everything? It's the basic that goes wrong. And that's where you have started. So what are the guidelines that we are still following is the WHO recommendations for antenatal steroids. It is recommended for lung maturity between 24 and 34 weeks. Now, since this is a guideline given by WHO, it has given 24 weeks because that is the viable gestational age for the developed world. But when you're sitting in a corner of a place like India in a village, and you know that this 500, 600 gram baby has no chance of survival, do not then put in all this management of steroid, Maxalf, etc., etc. Customize all the guidelines to our Indian scenario rather than following them blindly. So it is given, the steroids are given when the preterm birth is imminent within 7 days of starting the treatment. Mind well, do not give antenatal steroids empirically. So I remember when I was doing residency, twins, high risk, weekly steroids till delivery. It was very common in 2007. So do not empirically give steroids. Every drug comes with a cost of a side effect. Not the money cost, but the cost of a side effect. It can be given in single and multifetal gestation in the same dose. So if there are twins, do not give double the dose. It's the same dose that is required. If there is a rupture of membranes and there are no signs of infection, there is no contraindication to give steroids. So if a lady has come with PV leaking at 31 weeks, you know that you are not going to be able to pull on her further. Please give a steroid if there is no tachycardia, no fever, she has not had leaking for more than 12 hours, she doesn't have foul smelling discharge, there is no fetal tachycardia. So all these signs of acute and subacute chorioamnionitis are not present. You can give steroids safely. So it is very well also indicated in fetal growth restriction, preeclampsia, diabetes. So there was a time when it was thought that since the baby is already small in FGR, there is enhanced maturity because of increased steroid release. But it has been proven that FGR babies actually benefit more with steroids as compared to an AGA baby, as compared to an appropriate for gestational age baby. Preeclampsia, yes, you give a dose of steroid and her BP and sugar is going to shoot up, but transiently. So in high-risk mothers, especially preeclamptics, diabetics, hypertensives, it's a good idea to admit the mother and then give her steroid, because then you can monitor her sugars, step up the insulin, step up her antihypertensives, or at least keep her in HDU and call her back for the next dose. So do not give her steroid and send her home. Another problem with these high-risk mothers is they often come back with decreased fetal movements, and then it is very confusing whether really the baby is moving less, or is it that the mother is not perceiving it, or sometimes even after you give steroids, up to 48 hours you can observe that there are a few changes that take place in the mother and the fetus. And one of the most typical complaints that the mother comes up, you've given her second dose of steroid yesterday, sent her back home, okay, if you get pains, come back. And she comes back the next day saying, Mera baby nahi hil raha hai. And then you are scared because she's already a diabetic, she's already a hypertensive. Do not rush and deliver her, because corticosteroids are known to reduce the fetal activity. Corticosteroids are known to pseudo improve the Dopplers, but all the effects of steroids, that is the inotropic effects, will last only up to 48 hours, and all these effects are going to go away after 48 hours. So which steroid to be given? We'll come to that soon. The contraindications of giving steroid are the woman with chorioamnionitis. That's the only contraindication. Otherwise, even on a lady with insulin 80 units, she's come to you in labor, she's going to deliver at 32 weeks, please give steroids, because our neonatology friends are going to be very happy if you deliver this baby at 32 weeks. How much ever small the baby is, the maturity is way different when you give antenatal steroids versus when you give a surfactant. So in a gist, less than 22 weeks, in fact for India, less than 25 weeks probably, depending on your NICU, there is no benefit of really giving antenatal steroids for lung maturity. But between 26 and 36 weeks, give steroids to all mothers who are likely to deliver in the next 1 week. and it reduces the perinatal mortality and morbidity as well. Now, there was a guideline, there was a Lancet paper which said that steroids need to be given to all mothers for whom an elective cesarean section is done till 38 completed weeks. Now, this was in 2017 or 18, but in 2023 March, a new guideline has come up which says that beyond 36 weeks, the advantage of giving antenatal steroids for lung maturity is questionable. So you need to discuss it with the couple that if now I give steroids, these are the pros and these are the cons. And then you decide whether you want to give it or not. So up to 36 weeks, for sure you have to give steroids. After 36, discuss it with the couple. So what are the advantages of giving steroids? Yes, it significantly reduces the neonatal death, respiratory distress syndrome, intraventricular hemorrhage. And this was the paper I was talking about. But what was the problem of giving repeat steroids and also the steroids being given routinely after 36 weeks for elective cesarean section? It was realized that steroids also have side effects, especially when given again and again. So first, there is no significant benefit. Secondly, it does not, it increases the risk of cerebral palsy, which is very dangerous. Secondly, it increases the risk of the baby having necrotizing colitis. So these were the two very scary things that was observed with repeated doses of steroids, and therefore we have to be very cautious when we are giving the steroid dose. So what does the evidence say? When can you repeat a steroid? The only indication to repeat a steroid is known as a rescue additional course of steroid. Mind well, it's not a single dose. Whenever you give antenatal steroids for lung maturity, the whole course has to be given. Okay, so this rescue course that needs to be given, if no delivery has happened 2 weeks from the first steroid course. For example, at 28 weeks, she comes in threatened preterm. You think that she's going to deliver, you give her a steroid shot, and then she does not deliver, you send her back home. She comes back again at 31 weeks, but now she is in active labor and you know she's going to deliver. So since it has been more than 2 weeks since your previous steroid, plus she's still less than 34 weeks, and you are now sure that she's going to deliver, please give her this rescue course of steroid. This is the only indication for giving a repeat dose of steroid. All the hue and cry of whether to deliver or whether to keep the baby inside. Why is there so much concern? Anybody in metro cities would say that, okay, our NICU will manage anybody over 28 weeks. Then why do we want to count on each day for maturity? As you can see on the graph, up to 28 weeks, every single day that you keep the baby inside the mother's womb, you are improving the survival, intact survival, neurologically intact survival of the baby by 2% per day in utero. So suppose you deliver her today or you deliver her after 1 week by close surveillance, you're going to get an added advantage of 14 to 15% that this baby is going to do neurologically very well later. Okay, and after 28 weeks, it reduces to 1% per day in utero. But yes, every single day in utero is important for maturity. All the high-risk mothers will deliver around 37-38 weeks, whether it is severe preeclampsia, controlled on antihypertensives, whether it is diabetic mothers. Why do we use this 37-38? Why not 36? Why not 39? Why not 40? Now, there is this graph that shows up to 36-37 weeks, the risk of sudden abrupt intrauterine fetal demise is low if the mother's parameters are well controlled. But as soon as we cross 37-38 weeks, if you just look at these yellow and green lines, which is prospective stillbirth rate and prospective perinatal mortality rate, it suddenly peaks after 38 weeks, which means if you let these babies be in utero after 38 weeks, they are more likely to have stillbirth perinatal mortality despite a good control of the maternal condition. And therefore, the statistical benefit of delivery outweighs the risk of continuing the pregnancy beyond 37-38 weeks. Hence, an appeal to all of you, do not wait for the EDD. The EDD is 20th of January. Let's wait. The EDD is only assigned for us to have a fixed point against which we can gauge the growth of the baby on every scan, at every visit, which tests to do, beyond which date not to take her. But reaching the EDD in a high-risk pregnancy has to be interpreted with a lot of caution. When I say high risk, I include all these very high-risk mothers who are more likely to have the fetal acidosis. And as obstetricians, our aim is not to just cut the cord, deliver the baby, hand it over to the neonatologist, hear the cry and give the good news. No, this is not the end of the story. This is the beginning of the story. The end of the story is when this child comes back to you 5 years later, walks up to you, talks to you like any other 5-year-old. So a long-term intact survival is what we are looking at, and not just a live baby. And this is where all these principles help. Now, this whole argument between which is better, betamethasone or dexamethasone, I would want to hear from all of you later while we are discussing. But till a few years back, actually, in Pune at least, everybody used to give betamethasone, irrespective of the availability of dexamethasone. Okay, both have got similar action, but the problem is that in India, the salt on which all the studies have been done on betamethasone is not available. So betamethasone acetate plus phosphate is the salt on which all the Western studies have been done, on which all the guidelines are based, on which all the dosages are given. We are following those guidelines blindly, using their doses at their gestational ages, not realizing that India is not making the same salt. And the salt that we are making is not heat stable, has got a different mechanism of action, has got a different duration of peak activity. So what is available with India is the short acting, more frequently dosage required betamethasone phosphate, on which studies are not available in big numbers. And therefore, I would appeal to all of you that where available, please use dexamethasone. It's a more stable salt. More studies are known with dexa in the salt and the dose that we have been using. Yes, the only problem is it is available in 6 ml vials, and to give the doses, you need to reconstitute the dosage in a way that it becomes cumbersome, but it is totally worth it. And therefore, in 2014, the government of India has come up with guidelines. The picture on the left is the guideline given to the ANMs by the government of India, and this has been made by a task force of neonatologists and high-risk obstetricians, where they said that dexamethasone definitely has an edge in India because it is a more stable salt, and there is no added advantage of using betamethasone over dexamethasone. So that's the end of steroids here. We come to magnesium sulfate. It's the new kid on the block, no more new really. Last decade, we've been hearing all the guidelines, and I think it's a very well accepted fact that before 30 weeks, when a baby is delivering, please give magnesium sulfate for neuroprotection. So we just spoke about an intact survival, and this is one of the very key antenatal interventions that you can do to improve the postnatal outcomes. A lot of guidelines have come up. I've only put the major ones here, including the RCOG, WHO, Indian guidelines, Society of Fetal Medicine, Society of Gynecologists of Canada, and so many more guidelines have come up. And they all say, in fact, Cochrane, which never agrees to anything, it always has inconclusive results. Cochrane also agreed that neuroprotective role of magnesium sulfate in women anticipating preterm birth is established. So how does it act? It prevents exotoxic. I'll just skip this because all of you know about Maxulf more than I do. In fact, something really interesting about Maxulf is that the way it started, how was it known that Maxulf actually causes neuroprotection? So in the MAGPIE trial, where it was seen that severe preeclampsia was the woman with the severe preeclampsia was given magnesium sulfate to prevent eclampsia, and in the second phase of this particular trial, it was seen that the women with severe preeclampsia, the babies born to these women did better than the babies that were born to mild preeclampsia. And why was that so? The only difference in these two arms of women was that the women with severe preeclampsia was given magnesium sulfate to prevent eclampsia, whereas the women with mild preeclampsia was not given magnesium sulfate. And that led to the studies which said that magnesium sulfate is not just a tocolytic, it is not just a medication that can be used to prevent or reduce the risk of eclampsia, but it is an excellent neuroprotective drug. And therefore, before 32 weeks, in fact, 30 to 32 weeks is a gray zone, but before 30 weeks, please use Maxsulf before you deliver these babies. Just one slide on how much Maxsulf to give. So one thing you got to remember, the difference between antenatal steroids and Maxsulf is that when a woman comes in labor, you want to try to not deliver her for 48 hours because you want to have the effect of steroids, and then after the steroid window you want to deliver her so that the benefit is maximum. Whereas while giving magnesium sulfate, you need to remember that the closer you give the magnesium sulfate to delivery, the more advantageous it is. So suppose you've planned a cesarean for her tomorrow morning at 9 o'clock because her end diastolic flow in umbilical is absent today. Tomorrow morning at 5 o'clock, so 4 hours prior to when you're planning her cesarean, start her on a magnesium sulfate infusion and then do a cesarean at 9 o'clock. Do not forget to inform your neonatology colleagues that you have given Maxsulf to this baby. Because imagine the chaos in the operation theatre when the baby is born. It cries or does not cry depending on the situation. It's already preterm. It's fetal growth restricted. The mother has some morbidity because of which the baby is already limp. Probably the CTG was not reactive. For various reasons, the baby could be really not very active or cry. And along with that, we've given magnesium sulfate, which is also known to depress the baby. So unless we communicate this to our neonatology colleagues, they will not know that there is an element of depression in the baby because of the magnesium sulfate. And in case where the magnesium sulfate has been given for other reasons in higher doses, we know there are better antidotes available also. Our neonatology colleagues have to be aware that the mother has been given Maxsulf. Remember never to continue tocolysis when you are giving Maxsulf. I know you all would think that Maxsulf itself is a tocolytic, but the dose we are using here is only for neuroprotection. We are not talking about tocolysis with magnesium sulfate. We have better drugs for that. Now, why am I saying discontinue your tocolysis if Maxsulf is given for neuroprotection? Because when you are giving magnesium sulfate, you got to be 100% sure you're going to deliver the baby. You cannot just give Maxsulf and wait. You are going to give Maxsulf only when you are 100% sure. Maxsulf is not a drug like steroid where you can give it away and send her back home. Okay. Therefore, you stop all tocolysis, you give Maxsulf and you deliver her. This has to be followed in this order. What is the dose? Fortunately, it's the same dose that is commonly used to prevent eclampsia. And it's very easy for you all to explain to your the staff and the nurses that it's 4 grams IV loading dose over 30 minutes, 1 gram per hour maintenance infusion till birth or 24 hours, whichever is before, and then stop. Like I told you, 4 hours prior to the delivery is the maximum effect. Remember, delivery should not be delayed for Maxsulf administration. So the patient is coming, she is in contractions, you've already given a steroid, just give a Maxsulf and deliver. Don't wait for any action to happen. Okay. So when you give Maxsulf, even on the OT table, before giving a NIC for the cesarean, even that works. So don't be in two minds. Less than 32 weeks, give Maxsulf for neuroprotection. Now coming to a few cases, I have not included any scans here. I've included the very practical aspects of all these situations. Now hyperglycemia in pregnancy is of two types from a fetal medicine point of view. It could either be a diabetes that the lady already had before pregnancy, or it is a diabetes because the pregnancy challenge has been put up to the lady. So it's either a pre-existing diabetes or it is a gestational diabetes. Now pre-existing, there could be two. Either there is a type 1 insulin-dependent diabetes, or there is a type 2 where the lady is probably 40 years old. She's had diabetes since 35 years of age. She's on glyphosate and now she's conceived. So this is the pre-gestational diabetes. Now, GDM, we all are aware of all the cutoffs, and you all know much better than me how to diagnose GDM. But there is, why have I put this distinction here? Because the whole way in which you approach these two different categories of patients is totally different. So how you would monitor one category versus other, when you would deliver one with other, what problems will you face in one versus other? So this is what we will quickly discuss. I call them sweet mums because they are diabetics. How do you counsel them in the first visit? Now, the first thing is to distinguish whether this was diabetes present before pregnancy or it has come now. When you have done the mother's booking bloods and on the first visit itself the sugar is high, there is a very high likelihood that she has always been diabetic even before pregnancy, just that it was not diagnosed because she did not check it. The best way to distinguish and to convince the patient, because the patient is in a complete state of denial, नहीं मुझे शुगर हो ही नहीं सकता, मैं बिल्कुल फिट हूँ, मैं सिर्फ 32 years old हूँ. So the best way to do it is you do a glycosylated hemoglobin, an HbA1c. One of the only really good indications for doing HbA1c in pregnancy is to do it after the booking bloods when the BSL is high, to distinguish whether this was a pre-gestational diabetes or a gestational diabetes. And invariably, you will have an HbA1c of 7, 8, 9, 10, 11, depending on how bad, how poor the control of BSL was. And then you can counsel how further, because this HbA1c has done two jobs for us. Number one, confirmed that she was diabetic before pregnancy. Number two, it has given us an opportunity to counsel the couple that since your HbA1c was high, when there was organogenesis happening, when you didn't even know you were pregnant, periconceptionally, this has posed your fetus to a higher risk of birth defects as compared to somebody with a normal blood sugar. So all this needs to be done when there is high maternal blood sugar on booking bloods. Which is the aneuploidy screening of choice? There is a lot of confusion whether there is more Down syndrome in diabetic mothers, etc. So there is no connection between Down syndrome and diabetic mothers. You will do a simple NT scan. You will do a good anatomy check of the baby at 12 weeks because yes, these babies are more likely to have structural defects. You will do a double marker like any other lady, and you will do a uterine artery PI, which is probably more useful in this particular lady because the pre-gestational diabetes is a vasculopathy. It has affected the end organs of the mother, could be the eye, the liver, various parts of the body, the heart, the arteries. So this is a vasculopathy. And if the uterine artery pulsatility index is high in this mother, she is definitely a candidate to be started on aspirin and to look out for fetal growth restriction and preeclampsia as well. So we know that diabetic mothers are more likely to have preeclampsia as the gestational age goes further. Okay, so suppose she has missed first trimester screening, she couldn't do a double marker, or even if she has done it. Sometimes there are these very obese mothers, they could weigh 120, 130 kilos, and you are just struggling with the spine. Is it normal? Her glycosylated hemoglobin is 11, but she's wanted to continue because she's been trying, failed IVFs, trying for pregnancy for last 20 years, and now that she has a baby, her HbA1c was 11. So you cannot discourage her from continuing the pregnancy. At the same time, I got to safeguard myself because I'm not able to see the spine properly. One of the help we can take is, despite a low risk double marker, you can do a quadruple marker because the alpha fetoprotein in the quadruple marker can help us rule out an open neural tube defect in such women. But this is a very exceptional case. Usually with our machines, we can see the spine very well and see the anatomy very well. So what are the specific defects of a diabetic mother? We are all talking about pre-gestational diabetic mothers. So specific, the most specific pathognomic defect of a diabetic mother. Since Hiramat sir said there are a lot of PGs who have joined, let's answer this as a quiz at the end of the talk. Which is the one pathognomic defect? You name it and you think about maternal diabetes. Okay, so we'll come back to this later when we are discussing. Now, fetal echocardiography. Here I would want to take a minute to explain to you why we want to do a fetal echocardiography. We do not want to do a fetal echocardiography in GDM mothers. Why don't we want to do it in GDM mothers? Because by the time these women have developed diabetes in pregnancy, the organogenesis has already happened. So this hyperglycemia in pregnancy at the 24 weeks, 28 weeks is not going to affect the structures of the baby. It is going to affect the growth, the fluid and the Dopplers and etc. But it is not going to affect the structures of the baby. Therefore, do not send women for fetal echocardiography at 32 weeks when her fasting has come as 100 and postprandial as 150 for the first time in pregnancy. Because this is something, the pregnancy is thrown a challenge on her body where she is now responding with this particular way and has become a GDM. She is not more likely to have a baby with structural heart defects as compared to a normoglycemic woman. Then where is fetal echo important? It is extremely important in the pre-gestational diabetic group, whether it is type 1 or type 2. Irrespective of the BSL control, a fetal echocardiography is recommended at 22 to 23 weeks to look at the heart properly because diabetic women are very likely to have cardiac defects. Why did I say 22 to 23 weeks? It's also important that you send the patients at the right time because if you vaguely tell them, go at 24, 25 weeks and get an echo done. What if there is a tetralogy of Fallot at 25 weeks and she doesn't want to continue? You are not going to be able to help her. So the whole Indian law has taught us various things, one of which is that when you have a doubt about something, scan her at 23 weeks rather than 25 so that you have this opportunity to explain to the couple if they want to discontinue the pregnancy. So how is the HbA1c associated with fetal defects? This is mind well only on the booking bloods. This does not hold true on every trimester and once she has been diagnosed as a diabetic. So less than 6.5 HbA1c has a very low risk of congenital abnormalities. Between 7 and 8.5%, there are 5% risk of abnormalities, whereas more than 10, when the HbA1c when she got pregnant is 11, 12, the risk of having anomalies in the baby rises to more than 22%, which is huge. And the question that the couple asks you, like it's our exam, is that will you be able to diagnose these 22% defects on your amazing ultrasound machine, like Hiramat sir said? So how much ever amazing the machine or the person behind the machine is, there is a good 10% structural defects that cannot be diagnosed antenatally. This could be functional and this could be evolving. And we have to put this caveat on the edge of the report and counsel the couple. For example, duct-dependent heart anomalies, evolving coarctation of aorta, which was mild, so we did not pick it up antenatally, but presented post-birth. We can tell the parents that the baby has eyes, but we cannot show them that the baby can see. Similarly for the ear. So these are the functional problems. And mind well, the normalcy of the couple is a very difficult situation to handle. So always remember, do not scare away the couple, but put in this word of caution that yes, there are 10% of problems that could come up later or can be missed on scans, but be rest reassured because that holds true for everyone and not just you. Probably for others it is 5%, but for a diabetic mother it becomes 10%. So you got to do this as a part of your counseling. I'll not run through this. These are the risk of fetal and maternal neonatal complications of hyperglycemia in pregnancy. More theoretical, you all know that much better than I do. So when a lady comes to us before pregnancy, now this is an increasing trend and it's a very welcome change that women are now seeking help. That look, I had a fetal demise in the 7th month in the last pregnancy. I want to plan again. How do I go about it? So number one, you go back and check why she had that demise. So if it was a 3 kg baby at 28 weeks and she had a demise, even if she tells you that she was not diabetic, you cannot trust her because you know this is an uncontrolled diabetic with a macrosomia who had a sudden IUD. So this time what you tell her is, the first thing you check her blood sugars, make sure they are normalized before she plans pregnancy and not after she plans pregnancy, because like we said, even before she misses her period, the brain and the spine is already mapped. By the time the lady misses the period and comes to you, the brain and the heart is already mapped. Any folic acid, any sugar control after that is not going to change the fate of the organs that have already been mapped. So therefore, pre-pregnancy, try to improve her blood sugar control. Tell her to lose weight. Check her blood pressures. If she is a type 1 diabetic on insulin, look at the end organ damage. Do a fundoscopy. Look at the LFTs, the renal function test. How is her creatinine? Remember, how much ever fetal medicine comes in as rocket science, our number one priority is the mother. So you have to make the mother enter the pregnancy in a very optimal state of her own health to go ahead in this particular pregnancy. Another thing that you need to do is stop all the drugs that are not safe in pregnancy. So we have this FDA category for pregnancy where we don't want to give her drugs that are going to cause harm to the fetus, and we shift her to safer drugs, and then we tell her to plan pregnancy. A very simple intervention that we all should do for every adolescent who is visiting all of you in your clinics, whether it be for PCOS, she's just gotten married and she's come for a vaginal discharge, she's got PCOS, irregular periods, weight gain, hirsutism. Use this as a window of opportunity to start her on folic acid forever. Folic acid is a water-soluble vitamin, and the moment you give her folic acid, you ensure that when she comes back to you with a missed period, there was folic acid in the last 3 months while she was trying to conceive, and that's one of the best simple fetal therapies that you can do for the baby. Okay, so do not start folic acid once she misses the period, but start folic acid at any possible opportunity that you get, or at least 3 months prior to planning the pregnancy. We have gone through all this. Okay, so the growth patterns in diabetics. A lot of times, the first slide I showed you in this case, where we distinguish between pre-gestational diabetes and gestational diabetes. Now, what is going to be the difference between the growth pattern of the baby? We have always been thinking that diabetic mother, big baby, diabetic mother, big baby. It's not so. When the mother has had diabetes prior to pregnancy, she behaves like a hypertensive because her vessels are now clogged. She has got probably atherosclerosis. She's got end damage, end organ damage. She's got placentopathy, and therefore these babies of pre-gestational diabetics are more likely to have fetal growth restriction, oligohydramnios, impaired Dopplers, and they follow a typical trend of chronic hypertension as compared to GDM mothers. So what will GDM mothers have? Macrosomia, preferential distribution of fat over the shoulders, over the abdomen. Will have polyhydramnios. So we'll have pedal edema. So this is the next end of the spectrum. So on an ultrasound, when you find a small baby in a diabetic mother, do not feel why this diabetic mother has a small baby. It's probably because she's been having pre-gestational diabetes. So these are certain myths here that I have put in so that it will just help us counsel the patients. Now, termination of pregnancy is recommended for all women with high BSL at conception. I've told you so many bad things about hyperglycemia periconceptually. That doesn't mean that we go around terminating all pregnancies. Mind well, you and me are nobody to take a decision. So I work at Ruby Hall, which is the most posh hospital at Pune, but I also work at Bharti Vidyapeeth, where patients don't even pay 3,000, 5,000 rupees for the whole delivery process. But in both the places, my counseling remains the same. And believe me, the patients at Bharti Vidyapeeth will understand easily, will trust me, will not do doctor shopping, and will listen to what I say. So I offer them their options and I explain to them their risks and I make them choose. Because this is a prestigious responsibility given to the couple by God to choose their baby. Because how much ever you and me be counseling them and be legally safe in the end, saying that हमने तो आपको बताया था ये सब हो सकता है, it is the couple who has to take care of the baby. So for example, there is an HbA1c of 9. She comes to you, she's been married for 18 years, has not afforded any treatment, yet has taken some loan and undergone IVF, which failed. She lost all hope for pregnancy. She suddenly missed her period and came to you and she's pregnant. Are you going to counsel this lady with all the horrifying things about the baby? No. You will make her cautious that yes, you are at a higher risk. We will monitor you and the baby. Let us see how it goes. But I can assure you that 90% of the problems on the scan, I'll be able to tell you by 24 weeks. And if there is a major anomaly, I'll help you terminate this pregnancy. You have to take a risk of 10% and go ahead. But probably this is the only chance you have to have a baby. And if you counsel them in the correct way, they will make the correct decision. Now imagine the same HbA1c of 9 in a young, beautifully married couple just 4 months back. Unplanned pregnancy, young lady, Not even knowing she is diabetic, she gets the shock of her life, first that she is pregnant, and second that her HbA1c is 9. Do you think how much ever I break my head into this patient, are they going to continue this pregnancy? No, they will not, and they are right in their place. So the same HbA1c, the same 8 weeks, customize your counseling by giving them the pros and cons of the situation, and two groups of people will take two different decisions, and both of them are not wrong. So you don't sit there and decide for them. You tell them, it's like a menu card. You give them the options and let them choose. But you tell them the cost, the pros, the cons, the long-term effects, and you tell them everything. Once they have all the required information, then you can expect them to make an informed decision. So HbA1c is not an accurate test, and it's not recommended during pregnancy. So there was a lot of criticism once a guideline came in that every month we should do HbA1c, and suddenly then it was all or none. So stop doing HbA1c because it's not helpful, because the protein binding capacity in pregnancy changes and HbA1c cannot be interpreted correctly. But then the only indication, like I told you, is to distinguish between pre-gestational and gestational diabetics. Okay, now this is something that I would want to talk to you about. Normalization of, so a lot of times the woman will come to me and say, my HbA1c was 11, but believe me, today morning's fasting 70, postprandial 100. I am on 80 units of insulin, which is harmless to the baby. So she can take as much insulin as she wants. Her sugar is very well controlled, very nice. Doctor, my latest HbA1c is 6.2. Excellent. But sorry, I cannot forget that your periconceptional HbA1c was 11, and that is what matters to me, because I'm sitting here looking at the structures of your baby, and what decides the structures is your HbA1c when you were conceiving, when you didn't even know that you were conceiving. So I'm happy that you have controlled your blood sugars, but it does not reduce your risk for having a baby with structural defects. And this is something I have to often tell the obstetricians as well as the patients. So a lot of inertia in starting insulin because you have to prick, it's an injection. But believe me, it is the sugar it is the raised BSL in the mother that is teratogenic to the baby and not the insulin. How many ever units of insulin you are giving, it is not going to cross the placenta and harm the baby. It's going to provide an optimal maternal BSL control and help the baby. So do not have an inertia or a resistance to start insulin. नहीं कुछ नहीं होता, हो जाएगा, अगला 1 महीना निकाल लेंगे. IUDs and diabetics are sudden. They will not give you a warning. So it's your responsibility to prevent that BSL surge in the mother for any reason. Another thing, आपने sonography पे baby weight दिया है 2.9 kilos. So I'm going to give a good vaginal trial for this baby, and you leave it there. The residents are there. Okay, 2.9 kg, she'll deliver. She's a tall lady with good roomy pelvis. She goes into labor and the shoulder is stuck. क्या हुआ? Sonography वाले ने wrong weight बताया? No, probably it's still a 2.93 kg baby. But in diabetics, there is a preferential adipose tissue deposition on the shoulders. So even an apparently normal weighing baby, which is not macrosomic, can get stuck with shoulder dystocia. In short, have a very high clinical index for suspicion for shoulder dystocia, irrespective of the normal weight of the baby that you are expecting. So this is something that I wanted to tell you. Now quickly moving on to the other cases, they are relatively the short ones, probably just 5 more minutes. So 25 years old, previous 2 miscarriages. Now there's previous 2 miscarriages and the TSH is 37. What next? The cutoff is 5 for non-pregnant, 3.5 and 2.5 for various trimesters in pregnancy. So yes, you will order for T3 and T4. And what you will then, so the couple is the T3 and T4 come back to be normal. So this is a subclinical hypothyroidism where the mother is not symptomatic. The T3 and T4 are normal, whereas the TSH is very high. How do you counsel such couples? Number 1, the prognosis is excellent. There is no indication to terminate the pregnancy. Number 3, what you have to tell them, because they may not come back to you. Maybe they're from some other village, some other city. They will deliver somewhere else. On the first visit itself, in bold, in red flag, cord, blood, TSH and T3, T4, and repeat on day 7. The most correctable form of mental retardation is cretinism. It is congenital hypothyroidism. So the only sin, it is criminal to miss congenital hypothyroidism. And therefore, in such mothers where you have a high TSH in the first trimester, because the baby's thyroid is forming by 9 weeks. Up to 9 weeks, the baby is completely dependent upon the mother. So if because of any hormonal milieu change in the mother, it has affected the baby, the best thing is to find out after birth and immediately treat it. It has been shown that if you initiate the treatment of congenital hypothyroidism within 3 to 5 days of diagnosis, the baby's neurocognitive function reverses back to normal within a month. And that's the best thing you can do for the baby. A simple thyroid function test on the cord blood. I said do it on the cord blood and repeat it on day 7. So the day 7 is the real measure of the T3, T4 because on cord blood, there is a maternal hormone influence as well. Now, hyperthyroidism, something very tricky, that in the first 3 months, we have a situation known as gestational transient thyrotoxicosis. Very, very common, typically seen in very lean mothers who are constantly vomiting, who have hyperemesis. And there is very high serum HCG concentrations in the first 3 months of pregnancy, because of which there is a TSH suppression, because the TSH molecule and the HCG molecule mimic each other, and therefore she comes up as a gestational transient thyrotoxicosis. Do you need to treat her? You don't unless she is symptomatic. If she has palpitations, yes, you need to give her a beta blocker, but otherwise it's going to come back to normal. Check T3, T4 and go ahead with it. The problem with hyperthyroidism is that the baby could either have hyperthyroidism or hypothyroidism. Can you please give me water, beta? So the baby could either have hyperthyroidism or hypothyroidism. How does fetus have hyperthyroidism? The mother's high T3, T4 go to the baby and cause a high T3, T4 in the baby and therefore cause hyperthyroidism. How does the baby have hypothyroidism? If the mother is on anti-thyroid drugs, which can also cross the placenta and go to the baby, a euthyroid baby will then receive an anti-thyroid drug from the mother and cause hypothyroidism. Sure, water, beta, please. So these are the two mechanisms by which there can be fetal hyperthyroidism or hypothyroidism. How do you monitor it on scans? You look for goiter, you look for tachycardia, polyhydramnios, and fetal growth restriction. Hypertension, I'm not going into much details because all of you can manage it very beautifully. But just one message on hypertension that I would want to give you is that if the lady is already on a drug like ramipril, which is fetotoxic, please shift over to a safer drug before she plans pregnancy. So they usually come to you saying, that I'm a chronic hypertensive, I want to plan pregnancy, I have been on ramipril. The first job you got to do is to shift her to a safer antihypertensive and then make her plan pregnancy, because one of the biggest side effects of ramipril is bilateral renal agenesis, which is not treatable and which is lethal. And this is something that you can modify. So coming to the last case of epilepsy, actually. We find a lot of women who are epileptics who are conceiving or want to conceive. And the only two things you got to remember is high dose folic acid. Preconceptionally, like I told you, the spine will also always be mapped. So if she comes to you after missing periods, you're going to miss the window. You have not helped in reducing her risk for neural tube defects. Put them on high dose folate throughout pregnancy, not just till the 3 months of pregnancy. Secondly, you shift them from a multi-drug regimen to preferably a single drug regimen, and from more teratogenic drugs to more safer drugs. So now we have excellent levetiracetam and lamotrigine, which are very safe antihypertensives from the baby point of view and have shown excellent maternal control for epilepsy as well. In case she comes to you when she was already on valproate, you have to do a transvaginal examination. Tell your radiologist or fetal medicine person to do a transvaginal scan to look for the spine, the lips, the cleft palate, because we know that valproate is known to cause these deformities in the baby. So imagine a 19-year-old lady with an unplanned pregnancy who just got married, conceived on valproate, comes to you at 10 weeks. What is she going to do? At the same time, you have another lady, like I told you, 38-year-old, 2 IVF failures, conceived on valproate. What are you going to do? So again, the same situation, customize your counseling, give them a non-biased counseling and let them choose what needs to be done. So coming to the last slide, maternal and fetal surveillance go hand in hand. You cannot just draw a barrier between the mother and the fetus. The fetus can pose the mother at risk and the mother can pose the fetus at risk. So we need to monitor both in harmony with each other, and there is no counseling that fits everyone. One size cannot fit everyone. So if some patient asks you, what would you do in my place? I tell them the same thing. Forget me. If I find 5 different couples like you and I counsel the same thing, they will do 5 different things and all of that is correct. So you have to do an informed counseling and a decision making depending on that. So a team is many hands and one mind. Work with your team, not alone. Weigh the maternal benefits and fetal risks to obtain an optimal feto-maternal outcome. Preconceptional optimization is vital. If you are seeing her for IUD in this pregnancy, she may go to her village and deliver, but tell her, before you conceive the next time, come back to me. Just tell her this much and they will remember it. Because they're very receptive at that time. They know they've had an IUD, they don't want it again. So they will come back to you prior to the next pregnancy. So use this window of opportunity preconceptionally. Teamwork makes dreams work. One protocol may not fit all the fetuses and moms, so customize your monitoring and delivery decision making. So how much ever you multitask, you cannot do everything at the best. So there are people meant for everything. Use Google, use Zoom, do the counseling with geneticists, store DNA. You don't want to do anything. She doesn't want to waste money on chromosomal microarray. Just 2,000 rupees, you store DNA and call her after 2 months. Then she will be in a mind to listen to you. Okay, let's do a genetic workup. So jugadu, we Indians are jugadu. We try to find out something in between. So let's do things that are good for the patient and the doctor both to help them. Thank you so much for the patient listening. And I'm looking forward to all the questions and your inputs.
Dr. Pooja, it has been a spectacular talk. All the various aspects of high-risk pregnancies which were so effectively put in, and such meaningful slides for each of the high-risk situations, that wonderful take-home message for a practicing high-risk obstetrician, that if we stick on to these basic understanding of all the concepts which were put forth today, I think most of the queries would be answered and most of the results would be obtained, that we take precautions for each of these situations like diabetes or hypertension or thyroid disorders and epilepsy patient and it was really a wonderful presentation. There was one query which was put in as, when we give Maxelf just 4 hours prior to the delivery, whether there is a increased risk of PPH, because we know that magnesium sulfate can cause PPH before when we give it.
Magnesium sulfate in the mother, the reflexes, the respiratory rate, the increased risk of PPH, it is all more likely in this mother, but it is worth it because as excellent obstetricians, you are going to manage the PPH, but nothing is going to help the baby have the neuroprotection that you are giving with the PPH, with the Maxelf there. So it is, yes, it does increase, and therefore I was talking about the communication. If one doctor has given Maxelf and the duty is over, it is so important to give the over to the other doctor and communicate to the neonatologist that, look, this is what I have given. This is what you are anticipating intraoperatively or on the table. So that everybody is prepared for that. But it's worth it, ma'am.
Correct. Another query which I had for many days was that when the TSH level is high, when the patient comes for the first visit in the antenatal record, we find that it is more than 100. And many times there is a query from the couple and the people around that, since the neurodevelopment has already started, whether it is going to affect the fetus and what do we do in such scenario when TSH is high. But now I think everyone is cleared of the doubt that irrespective of what the TSH level, in the start of the pregnancy, once we correct it, then there will be a reversal of the situation which can arise because of the hypothyroidism or hyperthyroidism which is put in.
Very true, ma'am.
Can I have a question, Dr.
Very-
Rajeshri?
With more
Yes,
than
ma'am.
I have
Yes.
a question to
Yeah,
Dr. Pooja. Well, Pooja,
Yes, ma'am.
your talk was so thrilling and we were all glued to the slides. Congratulations on the excellent work you've done. You just mentioned that when they have an IUD and they're not ready for genetic counseling, just preserve their DNA. So how do we preserve this DNA? Could you just tell us?
So, ma'am, there are labs which will come with their containers and which will give you their guidelines. It's very simple. You take a tissue from the axilla of the baby, you cut the cord, and you take a thigh tissue. You put it in normal saline and put some antibiotics, put an amikacin or gentamicin, and you inform the collection person beforehand. They will collect it and take it and process it. After a week or so, they will send you a report as to how much DNA they have been able to extract from the tissue that you have sent. Invariably, after a month or two, this couple will come back to you saying that, now tell us why our IUD happened. Suppose you've ruled out hypertension and diabetes and all the obvious causes. And there are some metabolic disorders that can cause an IUD, which can be worked up on this DNA now. So then we involve a clinical geneticist, and the geneticist will be so happy that we have stored this DNA, because after 2 months, if we don't store the DNA, we have no proof of what has happened the last time.
Exactly.
And the disorders can recur. There are single gene defects that can recur again and again, and it can be very frustrating. So this 2,500 rupees of multiple abnormalities and IUDs in normoglycemic and normotensive low-risk women, so-called low-risk women, it helps a lot, ma'am.
So do the regular genetic labs do this? Do we just ask them for fetal DNA analysis? Is it? That's all we need to do.
There is this lady whom I'm planning to now abort. So
Okay.
please tell us the container or tell us your guidelines. So
Okay.
usually all these genetic labs like the Lilac Insights, LifeCell, MedGenome,
Okay. Yeah, thank you. Thank you, Dr. Pooja.
Yeah, there was a question by Dr. Rachana that most of the reports are inconclusive. I think if the sample is taken correctly and we take all the designated precautions mentioned on the collection of the sample, so storage of sample and transfer of the sample, most often in 98% of the cases we get it as some evidence of problem which is occurring. As I mentioned by Dr. Pooja, now we have very good labs who are serving and catering to. In fact, there is a line of such people who who come forth for offering the services that we have. Various permutations and combinations are available to do the investigations now, especially even for a bad obstetric history, when the fetus is aborted in the first trimester also, we can send the sample for testing. And so there are now very much it justifies that we have a genetic and fetal medicine committee, that because we see that so many new things are happening, and it is so exciting to find that the genetics has come up in a big way to establish the causative factor of disease and also in the prediction of the disease, so that a lot of help can be provided. Although we have only about 200 or 300 diseases maybe which can be described by the genetic abnormalities, but still it is a promising area. And over to you, Dr. M.G. Ramad sir, for your comments and for your advices.
Thank you.
Ma'am, how you collect the sample, and very importantly, what test are you ordering? So if you order karyotype, 90% of the times it's going to fail and come back. Dr. Rachana is absolutely right. But you're not supposed to order a karyotype, and you're not supposed to send it to a lab that is doing my renal function test and your spleen test. You are supposed to send it to an authorized genetic lab. You're supposed to set the right test. So what is the right test? Chromosomal microarray is the right test. DNA storage is the right test. These don't come back as failed. The karyotype comes back as failed, and therefore we are discouraging the use of karyotype on any abortus material.
Correct. Correct. Sir, M.G. Ramad sir.
Yeah, thank you. Thank you, Rajeshri. Pooja, I told in the beginning, brain and beauty. Okay. Beauty we had seen, but brain I had not heard. Because such a lengthy lecture I never heard of you. So beautifully you have said all these things. You will be a very great and popular teacher if you remain in the medical college only. where you are right now working at Bharati Vidyapeeth Medical College, University College, and where she is also a trainer and a guide for many theses in the fetal medicine. Pooja, you have covered these things. I thought she is a fetal medicine person. She will go show on ultrasound photos and do all that. Hardly you have shown any ultrasound photos, but you have covered. You have covered.
Yeah, because at the receiving end, I understand you have to communicate to the patient, because ultrasound I will do and give you the diagnosis. So ultrasound master classes are for radiologists or fetal medicine specialists to teach them the planes and the technicalities. But I believe in the obstetrician reading their own reports, interpreting it and counseling to the couple. So that is more.
I never thought that you are such a good obstetrician and such a good counselor also. And you have covered these 3-4 topics so well. You have made it very clear about steroids, because in spite of using steroids for so many years, many people, they do mistake. I think you have made it very clear and convincing also, that you have told why you must use only dexamethasone. You had given 2 reasons. One more reason has been given by refrigeration also, it doesn't need. One of the questioner had asked. I think you have covered this topic very, very well. And diabetes you have covered at length. I have no words to tell you how beautifully we have covered a pregnancy in a pre-diabetic, because pregnancy in a pre-diabetic is more dangerous for me. As you rightly told, the diabetic, the pathophysiology ends up with the end organ, and that will affect many of the organs which are very, very essential for pregnancy, including the placenta. I think pre-existing diabetes is worst, and it will end up with hypertension. And later on in the second part of their pregnancy, they become both diabetic and hypertensive. And you know that hypertension, if it adds up to diabetes, it will do very bad to the fetus. I think those are the worst fetuses which you are going to deal with them. And you have covered very well regarding the diabetes. And you have touched upon on thyroid also, and epilepsy also. Again, epilepsy is also very important. Nowadays, we are finding quite a good number of patients, they are becoming pregnant, they are coming with epilepsy, and hyperthyroidism also. Earlier, we thought that hyperthyroidism is not so common. Now we find quite a good number of cases of hyperthyroidism also. And you are stressed on preconceptional optimization. I think that is an area where we all have to work, because hardly no patient will come to us before they become pregnant. Only when they become pregnant, they will come, and all the things will start only after pregnancy. I think a lot of preconceptional clinics are to be introduced, and preconceptional counseling is also very, very important. And the sweet moms, you have said, now sweet moms are the greatest risk. Now regarding the shoulder dystocia, I have seen so many shoulder dystocia, so many babies we have lost. But now this problem is not so common. Hardly we see few cases of shoulder dystocia only when their baby's weight is more than 3.5. On an average, if the baby weight is around 3, this may not be a problem. But rightly you said that we don't have any gadget which will tell you what is the shoulder's transverse length. It is the shoulder's transverse length which will harm the rotation. In the cavity, when the baby has to rotate, if the shoulders are within that range of the cavity, then only it will rotate. I think that is the problem where you end up with. And textbooks have shown previously so many maneuvers. I tell you, all those maneuvers are only to read for PG exam.
Very difficult.
And please the examiner. When it is in the practical in the labor room, none of the maneuvers come to our saving. And that is the reason that most of these cases we are going for C-section, because C-section has become very, very common. And C-section is used very largely in all these diabetes. And rightly you said about the silent fetal death. In spite of all these advances, in spite of good fetal surveillance, still a unexplained fetal death can occur in diabetes. I think because of that also, we have to act. And she was so involved while giving this lecture that she started coughing, and now she's needed a lot of water to see. Now, over a time, you go on talking like this. When you become a teacher, you know, you don't get any hiccups or any cough, even if you talk for more than 2 hours. Rightly, very nicely you have done. It's worth inviting you, and our KCOG officers have joined. Quite a good number of postgraduate students have also joined, and you have given a very good insight into these surveillance of the fetus. I think this practical knowledge, these we don't get in text, we get with experience. A lot of people have got their where HbA1c role. I think you have made it very clear that though HbA1c may not help you in the diagnosis, but if you add your HbA1c with your routine diagnosis, it will help you to detect whether she was a pre-diabetic, diabetic already and endemic. That makes a lot of issue. I think you have done excellent, and congratulations to you. You be a regular member of our KCOG and be a regular speaker for our KCOG. Now I request our President, Dr. Vidya Thobi, to say a few words, and with that we'll end up, and Bharti
Yeah.
will give.
So I really thank Dr. Pooja to give the practical tips and her vast experience on fetal medicine. And I think we learned a lot from your talk. And you were so emotional and you were so involved in the topic that we could judge the depth of your knowledge also. So I always love to listen to you, as you know. And our postgraduates also have expressed that they have learned a lot. So you told that some quiz or something was there. So I had told my postgraduates that she will be posting some quiz. So at the end of your talk, usually you put some quiz. I think I missed that portion today. But anyway, it is too late, and you can post them. We can put it across, Pooja.
There was one we asked, has any PG answered, which is the teratogenic effect in the baby, which is pathognomic to maternal diabetes. Has anybody answered?
No, it was not there in any chat box. Nobody answered that. But I thought you give very excellent quiz and excellent brain churning questions. So that was missing today. So next time you please put, or you can put it to us so that we can put it to our postgraduates also. So thank you, Pooja, again, and please come. Our conference is there 15th, 16th, 17th of December at Bichapur. So you be a part of that because we are connected. We are very nearer to each other, AMOGs and Maharashtra and Karnataka, and together we do so many programs. AMOGs, Endocrinology Committee, Medical Disorders of Committee, Imaging Committee. We have done many webinars, and that has helped also. So we will again be in touch with you. And welcome to KCOG again. Thank you very much.
Dr. Pooja, Dr. Firdaus has answered to your question saying it may be phocomelia.
So one more chance to get the audience poll now. I can't give you 1 crore even if you answer correctly, but just one more try.
Yeah.
So it is sacrococcygeal teratoma. Sacral agenesis. You listen to sacral agenesis and you think about caudal regression syndrome. Yes, Dr. Sushma Badi. Yes. She got it. Okay.
She got it, yeah.
This is the answer. Caudal regression syndrome associated with sacral agenesis is economic of a diabetic.
So India has won the match. To conclude the session, my husband is clapping in the other room.
Now I request Dr. Suman Gaddi to give the vote of thanks. Suman.
Good evening, one and all. And I would first of all like to thank the entire KCOG and KCOG family, Chief Patron Dr. M.G. Rimat, Dean KCOG Dr. Hema Divakar, Chairman KCOG Dr. Muralidhar Pai, Vice Chairman KCOG Dr. Baswaraj Sajjan, Secretary KCOG Dr. Vidya Bhatt, for bringing up such wonderful programs at the national level. I also thank Dr. Vidya Thobi, President KCOG, and Honorary Secretary KCOG, Dr. Rajshri Palladi, President-elect Dr. Bharti Rajshekar for their valuable inputs. I also thank our today's guest speaker, Dr. Pooja Lodhe, for the wonderful talk on fetal surveillance in high-risk pregnancies. Talk was also supported by guidelines and all practical points, very important points that are important for day in and day out practice in various high-risk situations. I also thank all delegates who have logged in, and also thank Dr. Arun for providing the Zoom platform. I Everyone, good night.
Arun has
Thank
become
you,
doctor
Pooja.
with us now.
Take
Yeah.
rest today. Don't do any scans in the night today. Pooja, take rest.
Yes,
You have
sir.
done well.
My
Yeah, you have done wonderful.
Sir, my day starts now. My kids have exams tomorrow.
Thank you. Thank you
Thank you
very
all.
much.
Thank
Happy
you.
Dasara to all of us.
Thank you very much.
In another
Thank you,
Thank you,
month,
sir.
Pooja. All the best for your
another 2
children's
days,
exam.
Vijayadashmi festival is coming. Happy
Yes, sir.
Dasara to
Happy
each
Dasara Vijayadashmi to everybody.
everybody.
Happy
Yes.
Navratri to everybody. Thank you.
Yeah.
Thank you. Thank you. Good night.